Alright, so ready now?
Oh, turn on the mic?
No, this mic.
Alright.
Okay. Ready? Alright, so we're going to be going through the humerus today. I figure by now you guys would have gone through the skeleton, right? And you would have gone through how they divided the skeleton into axial and appendicular. So you have the basics already. So I'm going to spend some time now and go through the humerus in detail, right? Okay, so ready? All right. So as you can see, guys, I have two humeri here, and we're going to look and observe that the humerus has two ends. It has an upper end and a lower end, right? So the upper end is going to articulate with the glenoid cavity of the scapula, and then the lower end is going to articulate with the ulna and radius. So let's spend some time now looking at the upper end. First thing to tell you that the humerus grows from the upper end. So the upper end of the humerus is the growing end. So most long bones have a growing end. They either grow from the lower end or the upper end. But the humerus grows from the upper end. So we have a little mnemonic that we sometimes use. We say, to the elbow I grow. And then when it comes to the thigh now, we say, from the knee I flee. So it go from the lower end up to the hip. That means the lower end of the femur is the growing end, but the upper end of the humerus is the growing end. All right. So the upper end has a smooth, rounded head, as seen here, smooth, rounded head. And then, all right, so then there is, let's use this one. This one is more obvious. Then around the head, we have the anatomical neck. So this is the anatomical neck. All right. And then now, below the anatomical neck, look, this part of the humerus that's a little sort of constricted, this is the surgical neck. So there's a difference between the anatomical neck, which surrounds the head, and then a little bit below that now we have the surgical neck. We'll soon talk about the importance of the surgical neck. Now the head, the smooth head here, articulates with the glenoid cavity, which is this. I want you to observe how the glenoid cavity is shallow. Glenoid cavity is shallow. And by the way, the head of the humerus is relatively small. It's not as big as the head of the femur. And we're going to see what's the disadvantage of this for the upper limb soon, right? So, head, anatomical neck, surgical neck. Now, the important thing for the humerus, it has two surfaces. An anterior surface, which is the surface you're looking at now. And then the opposite to that is the posterior surface. So the key now is to be able to quickly differentiate between these two surfaces. So we're going to go back now to the anterior surface. And I want you to observe that the anterior surface has this groove on it towards the upper end. This is what they call the intertubercular groove. This is the intertubercular groove. Intertubercular because it's located between these two prominences, which are sometimes called tubercles. So this is the smaller of the two, called the lesser tubercle or lesser tuberosity. And then this one now is the bigger of the two. That's the greater tuberosity, right? So we have a lesser tuberosity a greater tuberosity. Notice now that this groove that's between them that we call the intertubercular groove, it's extending down the shaft of the humerus for about 5 or so centimeters. So not only is the groove between the two tubercles, but it's extending down the shaft of the humerus for about 5 centimeters, right? Now, on either side of this groove, on either side of the groove, we have this raised area, which is on the lateral side of the bone. Where the head is the medial side. So this is the lateral side. So this raised area on the lateral side of the groove is known as the lateral lip of the intertubercular groove. And then this not so prominent raised area on the medial side is the medial lip. So there's a lateral lip of the intertubercular groove and a medial lip. Now, we're going to spend a little time talking about the greater tuberosity. I'm going to spend a little time talking about the lesser tuberosity, as well as the groove and the two lips. So starting with the greater tuberosity now. If you look on the upper surface of the greater tuberosity, guys, take a look. If you look on the upper surface, there are 3 smooth areas. This area here is another smooth area right there, and below there's the 3rd smooth area. So there are 3 smooth areas that we call facets. Right? So there's an upper facet, a middle facet, and a lower facet. So 3 facets. These facets receive the attachment of muscles. So we're going to start with the upper facet or the superior facet. Superior facet receives the insertion of a muscle that's called the supraspinatus. We'll talk about that soon. Supraspinatus. So the supraspinatus inserts into the greater tuberosity, more specifically the upper facet of the greater tuberosity, right? Below that, we have the middle facet for the insertion of the infraspinatus. So the infraspinatus inserts into the middle facet. Somebody just called me. So we said the middle facet now receives the insertion of the what? Infraspinatus. And then now the lowest facet, which is this one here, receives the insertion of teres minor. Teres minor. So we've gone through 3 muscles so far that are attached to the greater tuberosity. One attached to the upper facet, that's the supraspinatus. One attached to the middle facet, that's the infraspinatus. And one attached to the lowest facet now, which is the teres minor. We're going to come back to these muscles again because I want to go through where these muscles are arising from and what the action of these muscles, each of these muscles is. So let's turn now to the lesser tuberosity. Again, I want you to notice that of the 2 tuberosities, the lesser one is closer to the head and therefore is more medial. So the lesser tuberosity is more medial and the greater one is more lateral. One muscle attaches to the lesser tuberosity, and that is the subscapularis. Subscapularis. Okay, so the subscapularis inserts into the lesser tuberosity. Now, these four muscles that I've just talked about are what they call rotator cuff muscles. So make a note that these muscles are rotator cuff muscles. They didn't find the person. You're at the wrong place, man. Where you are? Which something God is talking. No, come up more, man. You have to drive to past. Sorry, guys. Right. So these muscles we say are the rotator cuff muscles, right? Now, actually, these muscles are designed to increase the stability of the shoulder joint. Right? So the rotator cuff muscles are designed to increase the stability of the shoulder joint. What has happened is that for range of motion, for increased range of motion, we have given up stability for this increased range of motion. Okay? So the hip joint, when we get to the hip joint, you'll notice that the socket, which is the acetabulum, is quite deep, and the head of the femur is quite large. So we have this large head fitting snugly in a deep socket that increases stability of the hip joint. However, because we humans need increased range of motion for the upper limb, we have given up that stability. And it means that the shoulder joint, therefore, has become unstable. How do we fix that? The rotator cuff muscles help to hold down the head of the humerus in the glenoid cavity to prevent it from slipping out. Because the head of the glenoid cavity is so shallow, when we attempt to abduct like that, the head of the humerus slides out of the glenoid cavity easily. And so the rotator cuff muscles are now designed to keep the head into the glenoid cavity. All right? So we're moving on now. We're moving on. So going further down now, we talk about the intertubercular groove and the lateral and medial lips of the intertubercular groove. I have another humerus here where I have actually colored the intertubercular groove in green. The medial lip is in red. The lateral lip is in black. Now, the muscle that inserts into the floor of the intertubercular groove is the latissimus dorsi. Latissimus dorsi inserts into the floor of the intertubercular groove. On the medial lip, we have the insertion of teres major. So we have the insertion of teres major. And then on the lateral lip now, we have the insertion of pectoralis major. All right. All right, so just come up close here so you can see. Hi, nice meeting you. Okay, cool. All the best. Right, so we're looking at the humerus. You need to take a notebook and start writing. Okay, so now we have three muscles. Latissimus dorsi inserting in the intertubercular groove, inserting onto the medial lip, we have teres major. Inserting into the lateral lip now, we have pectoralis major. And so there's a little mnemonic that talks about the lady between the two majors. The lady being latissimus dorsi, and she's between teres major attaching to the medial lip and pectoralis major attaching to the lateral lip. Okay? All right. Now, come down a little further now. Come down a little further, and I want you to observe that again, going back to the head, we say the head is directed medially. So always use the head as your sort of, point of reference. It means, therefore, that this border of the humerus is the medial border, and this is the lateral border, right? So we're coming down the shaft now, and I want you to observe this area here about mid-shaft on the lateral side. See that? So the mid-shaft of the lateral side of the humerus receives the insertion of the deltoid. So we call it the deltoid tuberosity. So,
I have a question. From Mikhail. Yeah. It says the pectorals major attaches to the humerus.
yes.
So, yeah.
Yes. So repeat. So again, we talk about the lady between the two majors, right? So we talk about the intertubercular groove, and we said that's where the lady is attached. The lady being latissimus dorsi. Then on the medial lip of this intertubercular groove, we have the attachment of teres major. That's one of the majors. And then on the lateral lip now of the intertubercular groove, this black line represents the attachment of pectoralis major. So yes, pectoralis major is attached to the humerus, but we have to be specific and say which part of the humerus is it attached to, and it's attached to the lateral lip. But again, we also have to be specific. This attachment is actually the insertion. We're going to go through the origin of these muscles soon, all right? We're talking about these markings on the humerus. We want to know which muscles make the markings, and that's what we're talking about. But when we're finished now, we're going to go back, look at each muscle and talk about its origin, nerve supply, and action. Okay? All right? Moving down now, the shaft, we say that this now is basically on the what? Lateral aspect of the mid shaft, and this is the deltoid tuberosity. That is for the insertion of the deltoid. Of course, you know what the deltoid is? The muscle that causes the roundness of the shoulder. All right, moving on now. Moving on, look. On the medial side, so opposite where the deltoid tuberosity is, look. Opposite that, on this side, is for the attachment of the coracobrachialis. So we're going to say now, the medial aspect of the midshaft is for the attachment of the coracobrachialis.
Sir, or doctor?
We're going to go back on a little later and talk about where coracobrachialis arises from. All right. So now, the rest of the anterior surface, guys, the rest of the anterior surface, so all of this lower half of the anterior surface of the humerus is for the attachment of a muscle called the brachialis. So we're going to say now that the brachialis arises from the lower half of the anterior surface of the humerus. Brachialis. And by the way, brachialis is the most powerful flexor of the elbow joint. What's the origin? The lower half of the anterior surface of the humerus. So far we have talked about those muscles attached to the greater tuberosity, of which we said there were three: supraspinatus, infraspinatus, and teres minor. Talk about the muscle that's attached to the lesser tuberosity, which we said was the subscapularis. And the four muscles together now, we call the what? Rotator cuff muscles. We have a little mnemonic for them, the sits muscles. You can write that if you want. The SITS muscles, sits muscles. And these muscles help to do what? Stabilize the shoulder joint. And then we talk about the lady between the two majors. The lady being latissimus dorsi, and the majors. On the medial lip, we have teres major, and on the lateral lip, we have pectoralis major. We come down further on the shaft now, but we're on the lateral aspect of the mid shaft. That area is the area roughly the size of a coin. That area receives the insertion of the deltoid. Just opposite that, on the medial aspect of the midshaft, medial aspect, have to look, medial aspect of midshaft, we have the insertion of the what? Coracobrachialis. And then now, the only other muscle that's attached to the anterior surface is the brachialis, and it occupies the what? Lower half of the anterior surface. That's the brachialis. We said that muscle is probably the most powerful flexor of the elbow. All right, going down now to the lower end, I want you to observe that there are two expanded edges, one on either side. This edge here and this edge here. This, since it's, okay, let's start with this one. So this one here, since it's on the same side as the head, it's medial, so we're going to call this one the medial supracondylar ridge. So this is the medial supracondylar ridge. And of course, the other one opposite to it is going to be the lateral supracondylar ridge, right? Okay, so we have a medial and a lateral supracondylar ridge. Now, so for the lateral, let's start with the lateral. For the lateral supracondylar ridge, it receives the attachment of the lateral intermuscular septum. So the lateral intermuscular septum is attached to the lateral supracondylar ridge. And the medial intermuscular septum is attached to the medial supracondylar ridge. Now, these two septa, guys, these two septa separate the muscles in the flexor compartment of the arm from the muscles in the extensor compartment of the arm. I don't know if you can show this. Oh, you see this little sunken area here? Let's come around and look. You see this little sunken area here? This is actually due to the medial intermuscular septum. And on the lateral side, now we have another sunken area for the lateral intermuscular septum. And what happened is this septum is actually separating the muscles in this group, which is the flexor compartment of the arm, from the muscles in the extensor compartment of the arm. So that's what these two septae are doing. They're separating the muscles in the flexor compartment of the arm from the ones in the extensor compartment of the arm. In addition to that, there are some muscles attached to the lateral supracondylar ridge. What I've done, I've put a red mark on the upper 2/3 of the ridge, see that? And then a slight green mark now on the lower third of the ridge. So the upper 2/3 of the lateral supracondylar ridge receives the attachment of the brachioradialis. So write that. So the upper 2/3 of the lateral supracondylar ridge is for the insertion of brachioradialis. And then now, look on this now. The lower third now, which is where the screen mark is for the attachment of the extensor carpi radialis longus. So I'll say it again. So the lower third of the lateral supracondylar ridge, where this green mark is for the attachment now of the extensor carpi radialis longus. Extensor carpi radialis longus. Have that? Okay. Now, note also, guys, that we have a prominence at the lowest extremity. We have a prominence on the medial side, which is this prominence here, that is in yellow and red. Okay? This prominence here. Good. And then now, on the lateral side, we have another prominence too, although not as prominent as the medial one. So this one here. So we have two. Let me use this. So again, we have this prominence here on the side of the head, so that's medial. We have another prominence on the opposite side, which is lateral. This one is the medial epicondyle, and the smaller of the two on the other side is the lateral epicondyle, okay? So yes, these are important things to pay attention to. Medial epicondyle, lateral epicondyle.
Someone asked to repeat the upper second third.
Right, so the upper 2/3 of the lateral supracondylar ridge, upper 2/3, receives the insertion of the brachioradialis. Brachioradialis. So all of this area bounded by my index and thumb is for the insertion of brachioradialis. Okay? And then now, the lower third of the same lateral supracondylar ridge is for the attachment, we say, of the what? Extensor carpi radialis longus. You have that? Good. Extensor carpi radialis longus, and above it we have brachioradialis. So what we're saying now, we want to make a big point now of this prominence here on the lower end that we call the medial epicondyle, and this prominence on the other side, which is the lateral epicondyle. Important things, they like to ask this in the exam. Which year does this structure ossify? That's the medial epicondyle, and it ossifies in the 5th year of life. 5th year of life. And then now, the lateral epicondyle, which is not as prominent as the medial one, this one ossifies in the 10th year of life. So 5th year for the medial epicondyle and 10th year for the lateral epicondyle. Next, the medial epicondyle is sometimes called the common flexor origin. So common flexor origin. So the medial epicondyle is sometimes called the common flexor origin. Lateral epicondyle now, sometimes called the common extensor origin. So common flexor origin for the medial, common extensor origin for the lateral. So what are the structures arising from the common flexor origin? Structure arising from the common flexor origin are represented by my right hand, the fingers of my right hand on my left forearm, right? So my thumb, so all these fingers represent the muscles in the superficial compartment of the flexor compartment of the forearm, okay? So the flexor compartment of the forearm has two groups of muscles, superficial group and deep group. So the fingers of my right hand represents the muscles in the superficial compartment. So my thumb is the pronator teres. Pronator teres. So we're talking about now the muscles that are attached to the common flexor origin. So pronator teres, that's my thumb. My index finger, notice it's pointing towards the thumb on my left hand. So the index finger represents flexor carpi radialis. Flexor carpi radialis. My middle finger is palmaris longus. Palmaris longus. Hello? Yes? Represents pronator teres. Index finger represents flexor carpi radialis. Yes. Middle finger represents palmaris longus. Ring finger is pointing to my little finger on my left hand. So that's flexor carpi ulnaris. No, sorry, we did ring finger already? Or that's, I'm talking about ring finger now? Oh, we said ring finger was the flexor digitorum superficialis. Right, and then the little finger now is the flexor carpi ulnaris. So these five muscles are arising from the common flexor origin. Flexor carpi ulnaris. All right, so we talk about those muscles now that are attached to the common extensor origin, right? And the mnemonic for that is D-U-M-B, dumb. D-U-M-B, put, no, D, then under that you put U. Yeah, right. That way you can write what each letter represents. So D now is the flexor digitorium. The D is the digitorium. Flexor digitorium. Where does this muscle arise? It arises from the what? Lateral epicondyle, right? So U, the U now is the extensor carpi ulnaris. The U is the ulnaris. Right. M, flexor digiti minimi, sorry, extensor digiti minimi. Extensor digiti minimi. The mini-me is the M. And then the B now is the extensor carpi radialis brevis. Extensor carpi radialis brevis. Now, if you recall, just put recall. Recall that I told you that the extensor carpi radialis longus, D, is the extensor digitorium. Extensor digitorium. And the U now is extensor carpi ulnaris. Okay. Now what I was saying, if you recall that I said that the lower third of the lateral supracondylar ridge is for the attachment of the extensor carpi radialis longus, right? Now this muscle, the extensor carpi radialis longus, also gets a little origin too from the lateral epicondyle. Okay, so that's right. We're talking about the muscles arising from the lateral epicondyle and we represent them as dumb. You can also include extensor carpi radialis longus too. But just remember that most of that muscle actually comes from the what? Lower third of the lateral supracondylar ridge. Although it gets a little origin from the lateral epicondyle. You get that? Okay, you got that? All right, moving on now. All right, moving on. Still a little further down. Still a little further down, I want you to notice two little depressions on the lower end of the humerus. Two depression. This depression, this depression. Everybody can see that? All right. Now let me use this to demonstrate. Now, this structure, by the way, this bone is the ulnar bone that's located in the forearm. But this part of the ulna is the coronoid process, the coronoid process. When we flex the elbow, look what happens. The coronoid process goes into this sort of depression here, this depression. So we're going to call it the coronoid fossa. Okay? So on the lower end of the humerus, on the medial side, we have the coronoid fossa. And that is for the articulation with the what? Coronoid process of the ulna. You have that? Okay. Now, lateral to that is the radial fossa. So, coronoid fossa on the medial side, and lateral to that, we have the radial fossa. That is for the articulation of the head of the radius. So, when we flex, the head of the radius articulates with the radial fossa. So, there's a coronoid fossa on the medial side, and lateral to it, we have a radial fossa. Also, notice this rounded structure at the end now of the humerus. This is called the capitulum. The capitulum. Notice it's on the lateral side, opposite to where the head is. So that's the capitulum. And then on the medial side now, we have the trochlea, a sort of little depressed area called the trochlea. So the capitulum and the trochlea. Another very important thing to tell you, another important thing, young children, when falling on the outstretched hand, like that, falling on the outstretched hand, like that. The lower end of the humerus potentially can be fractured. Right along here, we call that a supracondylar fracture. So young children falling on the outstretched hand sometimes can get a supracondylar fracture. Let's write these things down and look them up. Supracondylar fracture. By the way, on this topic, the elderly, when they fall on the outstretched hand, when the elderly falls on the outstretched hand, they tend to fracture the distal end of the radius. So this is the radius, this is the distal end. They tend to fracture the distal end. So I have to make an important point. Young children, when they fall on the outstretched hands, they get a supracondylar fracture. When the elderly, especially postmenopausal women, they tend to get a distal radial fracture. Sometimes this fracture is called a remember, well, I guess you guys would know that still. You remember what they call a distal radial fracture? A Colles fracture. Colles fracture. C-O-L-L-I-E-S, Colles fracture. Good, so these are important things to pay attention to. Also, just looking on the bones of the wrist, this bone on the thumb side is known as the scaphoid. This is the scaphoid. Take a look. This is the scaphoid. And adolescents, when they fall on the outstretched hands, they tend to fracture the waist of the scaphoid. So make a note of that. So when falling on the outstretched hands, 14, 15, 16, 17-year-olds, they tend to get a scaphoid fracture. And the bone tends to be fractured at the waist. All right, so we're moving on now to the posterior surface now of the humerus. So we turn this over to the posterior surface. Posterior surface. Notice that we're not seeing the intertubercular groove. We're not seeing the greater and the lesser tuberosities as well. That's done. Well, the first thing is apparently estrogen protects the bone of women, right? So estrogen protects bone density. Once a woman reaches menopause and estrogen level falls, then she loses bone density. That is not to say when men get old, they don't lose bone density. Too, they do lose bone density, but not as fast as with postmenopausal women, right? So women are more prone to getting Colles fracture when they fall on the outstretched hand than men do. Also, when the young fall on the outstretched hand, children, I'm not saying that the only fracture they can sustain is a supracondylar. They can fracture also the clavicle, right? But with respect to the humerus now, they sometimes get a supracondylar fracture. All right, let's look on the posterior surface now. I must apologize because actually, apart from this, all the others that I have here are plastic, right? And that's why we're not seeing the markings on the posterior surface as clearly as we should. But if you look on this one is not bad. What we're seeing two lines, not as prominent as I expect. We see one on the medial side, and we see another one on the lateral side. All right, so let's make a note. Maybe later on, sometime later when I get my bones, you'll be able to see them well. But there are two parallel lines on the posterior surface, one on the medial side, one on the lateral side. The one on the lateral side, guys, is for the origin of the lateral head of triceps. So this line on the lateral side is for the origin of the triceps muscle, the lateral head of the triceps. And then the one on the medial side, this one here, is for the attachment of the medial head of triceps. So we have lateral head of triceps, medial head of triceps. In between the two heads, this area between the two heads is known as the spiral groove. So make a note of that, spiral groove. All right, so again, two parallel lines on the posterior surface, a medial line and a lateral line. Lateral line for the attachment of the lateral head of triceps, medial line for the attachment of the medial head of triceps. And in between the two now, we have the spiral groove. Spiral groove is sometimes called the radial groove. What runs in the spiral groove? The radial nerve. So the radial nerve runs in the spiral groove. It runs between the medial head and the lateral head of the triceps. These are important things to remember. What is this nerve accompanied by? It is accompanied by the profunda brachii artery. So when you get to fourth year, when you're doing orthopedics, you're going to come across mid-fracture of the humerus, a fracture of the mid-shaft of the humerus. And as a doctor, one of the first things you're worried about when the patient has a fracture to the mid-shaft, that this fracture, the jagged edges, could lacerate the radial nerve. Okay? Now the radial nerve controls the muscles in the extensor compartment of the arm and forearm, right? That? So you getting tired? So the radial nerve innervates. So the radial nerve innervates the muscles in the extensor compartment of the arm and forearm. So all those muscles that we mentioned just now, those muscles are innervated by the radial nerve. The triceps is innervated by the radial nerve as well. You get that? Now, you know what the tricep does? The tricep does the opposite of what the muscles in this group do. So the muscles here are the muscles in the flexor compartment of the arm. Those muscles flex the elbow. The triceps do the opposite. They do what? Extend the elbow. The muscles in the flexor compartment of the forearm, they either flex the wrist or flex the digits. The muscles in the extensor compartment extend the wrist and extend the digits. If the radial nerve is damaged, you know what the patient is going to have? He's going to have this. You know what this is called? Wrist drop. Okay? Wrist drop. Now, of course, in medicine, we don't like to assume and jump to conclusions easily. So you see your patient come through the door and he's like that. It could be, you could just like to walk like that, right?
Yeah.
So you don't want to jump to conclusions. So what do? He said, sir, could you point to the light bulb? And of course, for him to point to the light bulb, what he has to do? extend the wrist and extend the legs. If he can't do that, then he has wrist trauma. Okay? Now, and that tells you now that he sustained a fracture to the radial nerve here, mid shaft. All right? Okay. So we come down a little further now. Come down a little further and look what we observe. So there are actually only two muscles attached to the posterior surface of the humerus. And these are we say the what? Lateral and medial heads of triceps. Then we come down. This depression here on the posterior surface, look what this depression is for. This is known as the olecranon process of the ulna. And look, it fits snugly into this depression here. So this is the olecranon fossa. So olecranon fossa. So the olecranon fossa articulates with the olecranon process of the ulna. All right, so we want to go back up now and revisit some of these muscles that we mentioned earlier. Let's start with the muscles that are located on the greater tuberosity. Right? Muscles. Right, so this is the one we use. Right. So we say the greater tuberosity had a upper facet, middle facet, lower facet. Which muscle we say is attached to the upper facet? Supraspinatus. Let's talk a little bit about supraspinatus now. So the supraspinatus arises from this area here on the scapula. By the way, this is the spine of the scapula. So above the spine is the supraspinous fossa. Okay, so that's the supraspinous fossa, and this is where the supraspinatus arises. Then this muscle now, let me demonstrate something on it. So you can, right, so this muscle arises from the supraspinous fossa. So this is the spine here, supraspinous fossa, and comes over to insert into the greater tuberosity, right? When a muscle contracts, guys, the force of the contraction is in the direction of the origin. So what do you think this muscle will be able to do? Exactly, so this muscle will be able to do this, which is abduction, okay? So the supraspinatus is one of the most powerful abductors of the shoulder. The infraspinatus now, which we say is attached to the middle facet, arises from this area here in the scapula that we call the infraspinous fossa because it's below the spine, right? Infraspinous fossa. And its tendon also inserts into the greater tuberosity, or we say into the what? Middle facet. Now when this muscle contracts now, unlike the supraspinatus that is going to abduct, this muscle is a lateral rotator of the shoulder. So the infraspinatus laterally rotates the shoulder. By the way, both muscles are supplied by the same nerve. So both the supraspinatus and the infraspinatus are innervated by the suprascapular nerve. Good. And then now we have, this is what we call the lateral border of the scapula. We'll do scapula another time. That's the lateral border. Now this border is the border that's close to the axilla. So we sometimes call this the axillary border as well, okay? Now note, look, infraspinatus arising from this, and right beside it, teres minor is arising from the axillary border. So both of them are right beside each other. and they both insert into this almost the same place. The teres minor inserted into the lower facet, right? Or which is, since there are three, we said the lowest facet. And teres minor does the same exact thing as infraspinatus, which is what? Lateral rotation, right? And by the way, teres minor is innervated by the axillary nerve. All right. So far, with respect to the rotator cuff muscles, we have one that is an abductor, that's the supraspinatus. We have two that are lateral rotators, infraspinatus and teres minor. And then now, around here, this is the subscapular fossa. Which muscle arises from here? Subscapularis. And subscapularis inserts where? Into the lesser tuberosity. This muscle is a medial rotator of the shoulder. Medial. So subscapularis, medial rotator. So all of these muscles that we call rotator cuff muscles, one is an abductor, two are lateral rotators, and one is a medial rotator. All right. You get that? Collectively now, these muscles also do what? Stabilize the shoulder joint. Okay? We come down now. Guys, to the intertubercular groove. And we talk about the lady between the two majors. Let us talk about that one that's attached to the lateral lip of the intertubercular groove. We said that one was pectoralis major. Now, pec major arises from the chest wall. It arises from the chest. And it actually arises by two heads. Some say three. There's a third one that we often don't talk about because it doesn't have much significance. So there are two of them, two heads. We have a sternocostal head. So pec major arises by two heads, a sternocostal head and a clavicular head.
Someone is asking to repeat the last fossa. Oh, okay, subscapular.
Okay, right. So pec major arises by two heads, sternocostal head and a clavicular head. The sternocostal head, guys, arises from the upper six costal cartilages. And the manubrium and body of the sternum. Manubrium and body of the sternum. If you want these sessions to work well, when you get the chance, open your Netta Atlas and just look on the pictures. Everything that I've done with you guys, open your Netta Atlas, look on the pictures, and read what I've told you, and you'll find good to go. All right, so that's the what? Sternocostal head. The clavicular head now arises from the medial third of the anterior surface of the clavicle. Medial third, anterior surface of the clavicle. And these two heads now converge and insert into the lateral lip of the intertubercular groove. Pec major adducts, adducts, two D's, adducts and medially rotates the shoulder. Adducts and medially rotates. That's pec major. This muscle is innervated by the medial and lateral pectoral nerves. Medial and lateral pectoral nerves. Now, teres major. Look at teres major. Teres major arises from here. This is the, what is this? That's the inferior angle of the scapula. This is the superior angle. That's the inferior angle. So, teres major arises from the inferior angle of the scapula, and it inserts now into what we said, the medial lip of the intertubercular groove. The action of this muscle is the same as pec major, adduction and medial rotation. Now the latissimus dorsi is a little rough in terms of the origin. It arises, has a bigger origin. But you know, once you read it and commit yourself to this thing, you'll get it. So I'll start now. So latissimus dorsi arises from the following. I just list them. Latissimus dorsi now, the lady between the two majors. Latissimus dorsi arises from the lower 6 thoracic spines. So the spinous processes of the lower 6 thoracic vertebra. It also arises from all the lumbar spines, via the lumbodorsal fascia. So it's actually arising indirectly from the lumbar spines via the lumbodorsal fascia, also sometimes called the thoracodorsal fascia. So the lumbodorsal fascia is sometimes called the what? Thoracodorsal fascia. So it arises from the lower 6 thoracic spines, all the lumbar spines via the lumbodorsal fascia. It also arises, look, from the outer lip of the iliac crest. So outer lip of iliac crest. The lower 3 or 4 ribs, as well as the inferior angle of the scapula. So latissimus dorsi has a wide origin. Lower 6 thoracic spines, all the lumbar spines via the lumbodorsal fascia, outer lip of iliac crest, lower 3 or 4 ribs, inferior angle of scapula. And then now, the muscle now converges to insert into the intertubercular groove. Right? Now this muscle also adducts and medially rotates, but you can just imagine, look, you can just imagine when it's adducting, because it's around the back, when it seeks to adduct like that, it pulls the limb behind the back and does what? Extends the shoulder. So this is flexion of the shoulder, and the opposite of that is extension, right? So this muscle can be used when climbing and so on, but mainly it adducts and medially rotates, and it can also extend the shoulder. What's the nerve supply? The nerve supply to latissimus dorsi is the nerve to latissimus dorsi. Also sometimes called the thoracodorsal nerve. So you have to remember all these things. Also sometimes called the thoracodorsal nerve or the middle subscapular nerve. Middle subscapular nerve. I don't think I told you the nerve supply to teres major. teres major is supplied by the lower subscapular nerve, right? The teres major gets its innervation from the lower subscapular nerve. Now we come to the deltoid now. The deltoid. So we know that the deltoid inserts into the lateral aspect of the midshaft of the humerus, because we wrote that down already. So it inserts into the lateral aspect of the midshaft of the humerus. But the origin now, the deltoid arises from the spine of the scapula, as well as the acromion process, as well as the lateral third of the clavicle. So it has a triple origin: spine of scapula, acromion process, lateral third of the clavicle. And then it inserts now into the lateral aspect of the midshaft of the humerus. There's something interesting about the deltoid. It is, I don't know if you have learned this yet, but you know, muscles can be classified in different ways. One way is the muscle can either be a unipennate muscle, a bipennate, or a multipennate. The deltoid is a multipennate muscle. Multipennate muscle. It has anterior fibers, posterior fibers, and middle fibers. So we soon finish now, we're getting to the end. So it has anterior fibers, middle fibers, and posterior fibers. The anterior fibers lie right beside pec major. These anterior fibers can flex and medially rotate the shoulder, right? Can flex and medially rotate. The anterior fibers of the deltoid can flex and medially rotate.
Can you repeat the origin of the deltoid?
Yes, so the deltoid arises, we said, from the spine of the scapula, the acromion process of the scapula, and the lateral third of the clavicle. Then now, we said this muscle, so we're talking about the action of the muscle now. So we said the anterior fibers can flex and medially rotate. Posterior fibers do the exact opposite. They extend and laterally rotate. And it's the middle fibers now that are the what? Abductors. Middle fibers abduct. Then now look, opposite to that, we have the attachment of the what? Coracobrachialis. Remember we mentioned that? Coracobrachialis means that it arises from the coracoid process, which is this. So the coracobrachialis arises from the coracoid process of the scapula and inserts into the medial aspect of the midshaft of the humerus. Medial aspect of midshaft of the humerus.
What do the anterior fibers lie next to?
The anterior fibers of the deltoid, they lie just next door to pectoralis major. Pectoralis major. So open your meta-atlas, look on the picture, you'll see everything I'm saying. Okay, moving on. Moving on. Medial what is he asking?
Medial aspect of what?
What are we talking about?
I think in relation to the anterior fibrous question. I'm not sure.
Anterior fibers lie next to what? Anterior fibers is a lie. Oh, yeah. So the coracobrachialis, right? We say it inserts into the medial aspect of the mid shaft of the humerus. Medial aspect of mid shaft of the humerus. So it's basically the same place where the deltoid inserts, but the deltoid inserts into the lateral aspect of the mid shaft, whereas the coracobrachialis, medial aspect of the mid shaft. So we said the coracobrachialis arises from the coracoid process of the scapula. It's a small muscle, and right, it is considered to be a muscle in the flexor compartment of the arm. Okay. So this muscle is a weak flexor of the shoulder. Right. And of course, because it's a muscle in the flexor compartment of the arm, it is innervated by the musculocutaneous nerve. Musculocutaneous nerve. That nerve supplies the muscles in the flexor compartment of the arm. Musculocutaneous nerve. All right. Moving down now, and we come now to brachialis. I would say the brachialis arises from the lower half of the anterior surface of the humerus. So you have that written already. Brachialis, you can write it again if you want. Brachialis arises from the lower half of the anterior surface of the humerus, which would be right here. And it crosses the elbow joint to insert into the coronoid process of the ulna. So it inserts into the coronoid process of the ulna. Remember now, don't confuse coracoid process of the scapula with the coronoid process of the ulna. So which muscle inserts into the coronoid where this red mark is? That's the what? Brachialis. Now look, if this muscle arises from the lower half of the humerus, crosses the elbow joint anteriorly to insert into the coronoid process of the ulna. What can this muscle do? When the muscle contracts, the force is going this way, so it pulls up the forearm and flexes the elbow. And as I told you, in my humble opinion, brachialis is the most powerful flex of the elbow.
Someone is asking you to repeat. Someone is asking to repeat.
Okay. So brachialis, as the name suggests, arises from the what? Brachium. Brachium means arm. So brachium is arm, antebrachium is forearm. So the brachialis arises from the brachium. But we want to be specific here now. And we say it arises from the lower half of the anterior surface of the humerus. That's the brachialis. And it inserts into the coronoid process of the ulna. Because this muscle crosses the elbow joint anteriorly, it is a flexor of the elbow. It's massive, by the way. It's a massive muscle. And I think it's the most powerful flexor of the elbow. Again, brachialis is a muscle where in the flexor compartment of the arm, and therefore it gets the same innervation as the coracobrachialis, which is the musculocutaneous nerve. Okay? So you guys going to have to immerse yourself in the books Read every day. Every day. And guess what? This is your career now. So although it's rough and so on, it's your career. And what you're doing is building up knowledge little by little. Okay? So this is where the building starts now. From now, building up knowledge little by little, right? And the thing is, you're going to learn it and know it very well today. And when you start reading other things, it's gone from your head. So you have to find a way to revise here and there and so on, right? But don't get discouraged. Just continue reading, and you'll be fine. Okay? So that's the what? Brachialis. Then now, we want to talk about the muscle now that we said was attached to the lateral supracondylar ridge. Okay? We want to start off with the brachioradialis. And I want you to write, we said the brachioradialis actually arises now. That's the origin from the upper 2/3 of the lateral supracondylar ridge. Upper 2/3 of lateral supracondylar ridge. And look where the muscle inserts. It inserts right here. That's brachioradialis. Inserts right here. This is the styloid process of the radius. So brachioradialis arises from the upper 2/3 of the lateral supracondylar ridge and inserts into the what? Styloid process of the radius. All right. Now, this muscle, so in order for this muscle to get down to the styloid process, of course it has to cross the elbow joint. But it doesn't cross it directly anterior because the muscle is slightly on the lateral side. But it still can flex the elbow, although that's not the main action. The main action of brachioradialis, main action is demonstrated by this. Let me show you something. Just stand up. I'm going to flex my elbow like this, and you must stop me. Put your hand here. You don't have to put you can just clench your fist because you don't want to touch me, you know, because I don't want to contaminate your hand. So look, I'm going to flex it now and you push down. And everybody look and say brachioradialis, stand up, look. Do it hard. See this? That's brachioradialis. You see it? Do it hard. Good, that's brachioradialis there. All right? Now, brachioradialis can do this. It can mid-prone and mid-supinate. Right? So it can supinate the forearm midway. Now, interestingly, guys, remember I told you that the muscles in the extensor compartment of arm and forearm are supplied by the what? Radial nerve. But for some strange reason, this muscle finds itself almost in the anterior compartment of the forearm, but it's supplied by the radial nerve. So that tells us something. That tells us that this muscle used to be an extensor muscle. But for some reason, during our development, it has found itself almost in the anterior compartment. But its nerve supply has betrayed it. Right? It has told us the story. All right. So that's brachioradialis. And then now, we said the lower third of the lateral supracondylar ridge receives the attachment of the what? Extensor carpi radialis longus, right? That extensor carpi radialis longus. Now, this attachment is actually the origin of the muscle. So the extensor carpi radialis longus arises from where? Lower third of the lateral supracondylar ridge. All right, let me ask you a question now. Does this muscle arise from anywhere else?
Someone is asking to repeat.
Right. So the extensor carpi radialis longus. I don't know if that's what he's asking me to repeat. So the extensor carpi, okay, extensor carpi radialis longus arises from the lower third of the lateral supracondylar ridge. We have said that about 4 times already. So that's where it arises, right? And it also arises from where else? Remember I told you? Look on the notes that they have dumb, the dumb notes. Remember I said those muscles are the ones that arise from the common extensor origin. But I told you to also add what? Extensor carpi radialis longus, right? Although that's not the main place where it arises from, it gets a little origin from there. So it comes mainly from the lower third of the lateral supracondylar ridge and also from the lateral epicondyle. And it inserts now into the base of the second metacarpal. So we soon finish, guys. Let's have a few more things to say and we're done. Now again, being a muscle, it's an extensor muscle. And how do we know that? Remember we said the extensor muscles arise from the common extensor origin. So once we know it's an extensor muscle, what do we know also? We know it's nerve supply. Because we say all the muscles in the extensor compartment of arm and forearm are supplied by the radial nerve. So the extensor carpi radialis longus gets its innervation from the radial nerve. Okay, then now, of course, the muscles in there that are attached to the common flexor origin now, you already know what those are. Those are the muscles represented by my fingers on my hand right there. So we say pronator teres, flexor carpi, radialis, palmaris longus, flexor digitorum superficialis, flexor carpi ulnaris. Those are the 5. Okay? All right. And then now, we want to just finish off now by talking about the triceps. Finish off by talking about triceps. So we said the triceps, as the name suggests, arises by 3 heads. What's that? Right? So we have a lateral head. Where does the lateral head arise from? It arises from the what? Posterior surface of the humerus, right? Above the radial groove. Posterior surface of the humerus above the radial groove. That's the lateral head. Medial head, guys, of the triceps again arises from the posterior surface, but this time below the radial groove. So the medial head of triceps arises from the posterior surface of the humerus below the groove for the radial nerve, which is the radial groove. You get that? And then now, which part of the posterior surface do you think the other head comes from? What's the other head? Well, we have only gone 2 heads. Which other head? The other head is the long head. So there are 3 heads to the triceps. Medial head, lateral head, and the long head. The long head actually don't come from the humerus at all. The long head arises from here. From here. This is the infraglenoid tubercle. This is the glenoid fossa. This is the infraglenoid tubercle. So the long head of triceps arises from the infraglenoid tubercle. So that's another important point to make. 3 heads, 2 are coming from the posterior surface of the humerus, and 1 arising from the where? Infraglenoid fossa, right? The 3 heads converge now and insert into the olecranon process. So the three heads converge and insert into the olecranon process of the ulna. What's the action of the triceps? You tell me. What's the action of the triceps? Why don't you tell me? Huh? But you have to say extension of your knee. What's the, not the elbow, right? So it extends the elbow, okay? And of course, you also know the nerve supply. Right, so the medial head of triceps arises from the posterior surface of the humerus below the groove for the radial nerve, which is the radial groove. So below the radial groove. And then now the three heads now become a big shiny tendon and inserts into the olecranon process. Okay? Now, so the triceps is supplied by the radial nerve. And we're done. Okay? So for this to make sense now, you guys have to read it. Don't leave the information in the book. Read it up, right? All right, guys. Thanks for coming. And I wish you all the best. But reading. Everything I've said is in the last. Everything I've said is in the Netta Atlas. All right? So see you again soon. Bye. All right.
Hey guys, can you hear me? It's Shaleka. Let me know if you guys can hear me. Yeah, guys, remember we have a tea with Umed session right now at not right now, sorry, at 6 o'clock. So remember to join that because we're gonna have a lot of information regarding your first year, all the tips, everything you guys need to know. So make sure you guys are there. I hope this anatomy session was good. I'm pretty sure you guys learned something.
These girls here, at least I'm talking.
Thanks for coming. Yes, guys, this will be recorded. A link is in the group, so you can access that link from there. I'll ask Romario to resend the link. And yes, don't forget the tea with Umed, guys. It's going to be awesome. Be there. Tea will also be recorded, but yeah, it's good if you guys can make it so you can ask your questions and, discuss and whatnot. Yeah. You're welcome, guys. Yeah, thanks for coming.
Bye, guys. All right, guys. Have a good day.